Hello, I am Dr. Leonard Berlin, Professor of Radiology at Rush University and the University of Illinois in Chicago. Today we're going to talk about obtaining informed consent for radiologic exams utilizing ionizing radiation. It is, as you will see, a legal and ethical dilemma. Let's start off by quoting the former chairman of the General Electric Corporation, Jack Welsh, who made an interesting statement. He said, "One thing I've learned during my years as a CEO is that perception matters. And in these times when public confidence and trust have been shaken, I've learned the hard way that perception matters more than ever." Well, what is the perception of the public? Well, let's look at headlines in newspapers. And these are headlines that have been prominent in national newspapers, local and national papers for the past several years. Here's CT scans, cancer risk linked. Thousands of cancer cases from CT. And the headlines, those are major headlines. How about some of the smaller headlines? Look at this. The benefit of catching a serious brain injury may be outweighed by the dangers of exposure to radiation from a CT scan. 1 in 1,100 children who receive CT scans may eventually die from a cancer caused by excess radiation. A 45-year-old woman with history of kidney stones who had 70 CAT scans over the last 22 years raised her lifetime risk of cancer by 10%. Even the lowest amount of exposure to radiation has some risk. These headlines are scary and frightening. Here's a USA Today first page headline, front page. Overuse of diagnostic CT scans may cause 3 million excess cancers in the US over the next 2 to 3 decades. And this, I think, is the best or worst of all the headlines. This was a Chicago newspaper that headlined 2 or 3 CT scans equals Hiroshima radiation. Overstatements? Absolutely. Frightening? Scaring? Yes. Bad perception? Yes. And then, of course, it was all topped off by the last year's problem with Fukushima nuclear reactor accident. So there's been a tremendous publicity about radiation and cancer, most of it related to CAT scans, but even that which is not related to CAT scans, people think about CAT scans. Well, there's an old saying that says, perception is reality. Well, but perception is not really, nor will it ever be really reality. But what is reality is that there is a debate, argument, difference of opinion, contrary interpretation of data relative to radiation and cancer. That is the reality. Well, let me talk about consent. What is consent? Well, there's a legal term that we use in medicine, implied consent. There's 2 kinds of consent. When when a patient goes to the doctor, or let's say a radiology department, they say, please get up on the table, we're going to do an x-ray, or please hold your arm out so we can inject some dye into your arm. That's called implied consent. You don't have to say you're going to consent, but the fact that you get up on the table willingly and the fact that you open up your arm willingly, that's what we call implied consent. So it's patient's actions rather than spoken words, in other words, voluntarily climbing on the table, etc. But then there's also what we call express consent or informed consent. That is explicitly stated. That is required in medicine for any patient about to undergo a procedure that is not considered simple. Now, informed consent is when the physician comes, whether it be a radiologist or a non-radiological physician, comes to the patient and says, this is the procedure, this is what we're going to do, this is what we want to do, why we want to do it, these are the risks, these are the benefits, you have options, alternative options if you wish, there are risks of not doing it, and then the patient gives permission. The patient gives verbal permission and written permission to grant it, and of course, since the patient has the right to grant permission, they can always withdraw permission at the same time. Well, when is informed consent required? Well, here's one article from Mayo Clinic that says that basically, as a summary, it's required for all severe risks, in other words, death, paralysis, loss of cognition, even if the probability of it is negligible, but it's severe, or the less severe risks if there is a frequent occurrence of the problem. And of course, generally speaking, from a legal medical point of view, nominal risks with low probability need not be disclosed. Well, when we talk about significant incidents of complications, let's talk about that for a minute. Now, this happens to be a very interesting appeals court decision from Iowa some years back on the subject. And what the court said was, not all risks need to be disclosed to a patient, only the material risks. Here was a case where there was a fatal death as a allergic reaction to an IVP dye that was given to the patient. And the court went on to say the evidence was presented that 1 in 100,000 patients will die as a result of the injection of contrast media. And the court concluded that no prudent or reasonable juror or patient could reasonably have considered that risk to be material requiring consent. So what the court said in this particular state is 1 in 100,000 is insufficient to give consent. You don't need to. Well, that's one court decision. But this is a very interesting article. It was a survey of patients. Now, there's a very rare complication that occurs in certain kinds of surgery, spinal fusion surgery and so forth. It's an eye problem where actually a person can become blind. It's called postoperative visual loss. The incidence statistically is 0.2%. Now, 0.2% is pretty minimal. And many courts would say, well, a serious abnormality of 0.2% is not sufficient, does not have the frequency sufficiently to give consent. But nevertheless, a survey of patients say that 80% of the patients would want full disclosure of that particular rare situation. So the courts may say one thing about statistics, but the fact of the matter is, it's very difficult for patients to say, well, no matter how rare the complication was, I would want to have known about it. Now, to obtain informed consent, we have to give facts to the patient. As I say, types of complications, likelihood of occurrence, and so forth. Obviously, without facts, there cannot be informed consent. Well, if we look in the dictionary for the definition of fact, fact is defined as something that has been objectively verified. Well, now we come to the relationship between radiation and cancer. The claim that cancer will develop as a result of radiation exposure to diagnostic examinations is not, nor is it based on fact. Actually, in most medical procedures, there are hard facts available. We look in the literature. And when it comes to radiological procedures, all we have to do is look in the literature. We find that there are specific facts regarding the likelihood of a collapsed lung or a pneumothorax following a thoracentesis. There's facts regarding the likelihood of hemorrhage following an arteriogram, likelihood of anaphylactic reaction from contrast media, likelihood of perforation of the colon during colonography, likelihood of thrombosis following angioplasty, likelihood of stroke following cerebral angiography, likelihood of complications following percutaneous biopsies, abscess drainages, and other miscellaneous procedures. We can find facts, statistical facts, proven facts. Well, now when we come to radiation and cancer, we don't have facts, because there we have hypotheses, theories, conjecture, estimates, projections, extrapolations, statistic probabilities, opinions, all very important things, but they are not facts. And that's one of the dilemmas that we're going to face. So again, look at the so-called facts that have been published in the literature, in the radiologic and non-radiologic medical literature. And these are our publications. These are not newspaper headlines, these are publications. 29,000 cancers every year, half of which will be fatal, will result from past CT scan use. Radiation from 19,500 CAT scans performed every day in the U.S. will translate into additional cancers. Now, this is from the medical literature. Here's another. Lifetime risk, cancer risk due to radiation from a single coronary artery calcium score CT scan at the age of 40 is 9 cancers per 100,000 in men, 28 cancers per 100,000 women. In other words, according to this statistic in the medical literature, a 40-year-old woman is 28 times more likely to develop cancer from a CAT scan than dying from an intravenous injection of contrast media. Well, now, if this were true, really, all radiologists would be negligent for failing to disclose this fact every time they give a contrast media injection. So that's the problem. Now, it's interesting, one of the courts, this happens to be a Kansas appeals court, did deal with fact versus theory. It had to do with a radiation accident, an industrial nuclear reactor accident. And what the court said, in matters of determining the cancer risk from low doses of radiation, scientists do not deal with what exists in fact. Rather, they deal with theory, hypothesis, and assumption which cannot be used to establish legal cause. Law needs to be founded on more than a theory or hypothesis, said this court. Now, we have other statements. We have obviously a debate, a valid debate in the medical literature by good, prestigious, well-known, and respected radiation physicists on both sides. Here's one, this is from the Mayo Clinic, a physicist that says, we do not consider CAT scan exams performed as part of a non-interventional procedure to meet the threshold of risk for which informed consent is appropriate. All right, that is an opinion, obviously an educated opinion. Now, the problem is, or the issue is, that although courts generally do not require full disclosure of every conceivable risk and complication of any medical test or procedure, there are no clearly defined rules governing what needs and needs not to be divulged to patients. I quoted one or two court decisions, but they are single court decisions that have no particular bearing on what other states will do or other cases will do. So the issue is that currently there is insufficient data from the scientific community to justify an unequivocal determination of whether cancer develops from diagnostic level radiation. As a matter of fact, as an article from Mayo Clinic pointed out once, one may not know what should have been disclosed as part of a medical consent until the lawsuit is filed and resolved. So we come now to summarizing this issue of the dilemma. We talk about the law, the connection of the law, radiation, and cancer. Obviously, the courts. The courts are open to any aggrieved individual who wishes to file a lawsuit. In civil litigation, matters are decided not on certainty, but rather on more likely than not. Malpractice lawsuits are civil litigation as compared to criminal litigation, where it's beyond a shadow of a doubt. But in civil litigation, the burden is more likely than not, in other words, 51%. So it is unlikely that courts, I think, certainly they haven't decided yet, and I think as we look ahead, it is unlikely that courts will ever decide with certainty whether diagnostic level radiation is carcinogenic, but on a case-by-case basis, they will decide whether liability is imposed when such an allegation is made. So let's boil it down to the radiologist's dilemma. Yes, we have a legal and moral duty to disclose potential complications based on fact to patients and obtain their informed consent given. But do we have the same legal and moral duty to disclose to patients conjectures and unproven theories regarding whether diagnostic level radiation causes cancer? I wish I could give you the answer. But this dilemma has no solution today and may not, in fact, not only may not, but probably will not in the foreseeable future. W. Somerset Maugham, the famous English author, who, by the way, happened to be a physician, said, "There's only one thing about which I am certain, and that is that there is very little about which one can be certain." He wasn't thinking of radiation and cancer, diagnostic level radiation and cancer, but I think it's very fitting and proper. F. Scott Fitzgerald said, "The test of a first-rate intelligence is the ability to hold two opposing ideas in the mind at the same time and still retain the ability to function." And I think that we radiologists and other non-radiological physicians and allied personnel have to take these two quotations and consider them, because I think we do have to be ambivalent about this. We should be aware of these issues, but we should not be have great certainty on one side or the other. So obviously, if we communicate, we have to communicate to patients. Certainly a fundamental precept of the physician is to do no harm. We physicians are healers, but we are also educators and teachers. Thus, I think we must encourage, rather than discourage, public attention and discussion regarding this issue of radiologic imaging and the associated radiation exposure. Actually, if I quote one of the American College of Radiology practice guidelines that has to do with radiation in a pregnant woman, I think the statement that is made here is apropos to all kinds of diagnostic radiologic facilities. It says, "Conveying information in a positive rather than a negative format helps patients understand an accurate perspective of risk. Rather than saying there exists certain likelihood of cancer, that cancer could develop later in life, a message with a positive, accurate perspective is the cancer risk is small and the likelihood you will remain healthy with no adverse radiation effect by having this examination or CAT scan is only slightly different from any other patient not undergoing this exam. And I think this applies to CAT scans and all other radiologic procedures too. 25 years ago, back in 1985, Lawrence Taylor, who was a very well-known, obviously he's now passed, radiation physicist, said that he described the public's perceptions regarding radiation exposure and hazards as a cloud of ignorance and misunderstanding, that there's a common feeling among the uninformed public and the news media that radiation is so mysterious that even the scientists don't know what's happening. Well, in part that's true. We do know what's happening, but the fact of the matter is, and certainly there is not a cloud of understanding or ignorance on our part, on the medical community's part, but there is doubt and there's lack of certainty. That doubt and lack of certainty was present 25 years ago, in 1985, and it's equally present right now. Well, what can we do in the radiology community? Certainly we have what we call the Image Gently campaign. It was launched in 2008 by the Society of Pediatric Radiology, a combination, American College of Radiology, and other associated organizations, including the Association of Physicists. It's a national initiative to educate providers, doctors, non-radiologists, as well as radiologists in the public regarding radiation doses generated by diagnostic imaging, especially in children, but applying to everyone. So it's interesting, this was a survey just published in the Journal of the American Medical Association just a couple of months ago. And it was a survey of patients who presented for a CAT scan, and they asked certain questions. Well, of the patients, 51% had heard nothing from the media over the past year about radiation. 2/3 believed that their scan was definitely necessary. 40% reported thinking about radiation prior to the scan. 90% felt it was important to be informed of imaging risks. 1/3 did not know that the scan even exposed their body to radiation. That's an interesting survey. But in other words, in the end, we have a conclusion. Certainly it is the responsibility of clinicians, the non-radiological physicians, to ensure that each CAT scan is indicated, to order the least invasive modality with the highest certainty of success, and to discuss the case with the radiologist when unsure. Now, from our standpoint, from the radiologist standpoint, it is the responsibility of the radiologist to understand radiation doses, review requests involving high-dose studies, use appropriate technical factors, and discuss this with clinicians and/or the patients when appropriate. And this concludes my dilemma. Hopefully I have not solved the dilemma, but I hopefully have explained it a little bit more fully, and I thank you very much for your attention.